Caesar, Dirce, and Freddie, I have specific things that I know that you want to talk about, and I want to ask you questions related to those. But first, broadly, we've heard from the U.S. government officials about the broad objectives of country ownership, and I wonder if any of you have some general reflections. Are you make total sense to you? Can we go on and proceed? Or before we go to the next stage, are there things that you would want to nuance or to point out in relation to those objectives? Dirce. Maybe we don't want to yank either of these out. Maybe that one's closer. Yes, thank you.
I'm very happy to be here with this big audience, a bit nervous. But in fact, as Nandini said, we had a huge of 3 years of research in our specific countries. So I would like just to add some ideas or to make a general comment based in the research in Mozambique. And the broad comment I would like to make is actually related with this point of the country to be sitting in the driver's seat. And this point, through all the topics we addressed, one of the biggest finding is that in Mozambique, country ownership is most equals to national government. And we think that an important advance in the country ownership is exactly the involvement of the different stakeholders at the different levels of the health management system. I mean, provincial directorates of health, district directorates of health, health facilities, and also all the stakeholders in what we call the civil society. Along the discussion, we also can be more specifics about of what is this, the civil society. And with a more involvement, these all stakeholders can contribute for a more effective use of aids. So they can influence on the definition of the priorities, and also they can be implementers. So this is the general comment I would like to address from.
We mentioned this before when we were meeting, and I had a question then which I saved for now. So you don't know I'm going to ask this question. But as I understand it, you're saying that country ownership so far has been defined in terms of engagement of the donor, in this case the U.S. primarily, with the national government, and you'd like to see much greater participation of the subnational units. But it seems to me there's possibly a tension there between, if it's really national ownership, then that's not a request that one directs at a donor. That's a request that you direct at your own national government. And if the U.S. government, for example, or the Global Fund, then involves a lot of subnational units and consults with them, I fear we're going down a path that Minister Tedros proposed. You're setting up a parallel structure. So are you suggesting that for example, the Global Health Initiative or PEPFAR in this case would be working with all these subnational units, and isn't that then run the risk of undermining the national government's own efforts?
No, in fact, I don't think so. My idea is like Minister Metros approach very correctly. There should be a national vision and should be a clear coordination and harmonization of programs and policies at the national level. But there's a need for actually a more effective involvement of the subnationals. I can just go a bit ahead in your point.
Please.
In Mozambique, we have a well-established swap approach. I believe people here knows what
sector-wide
approach for programming, where most of the donors participate, including PEPFAR and the US government. So we have a very effective way of jointly established priorities and programs, and then implement. The problem comes because the money and the resources stay quite at the central level. So we have problems. I agree with Minister Tedros about budget support, and Mozambique is one example of most of the donors channel the money for the budget, but we have many difficulties in using the funding. There is a very low absorptive capacity from the Ministry of Health. So my proposal is exactly to flow the money for the local levels, and the donors should, with the government, define mechanisms to guarantee that the money flows and it can be effectively used to answer to the health needs.
Dirce, thanks very much. Freddie, I see you had your hand up, and I think that what you have to say may build on this nicely.
Thank you very much. I just wanted to back up a little bit about ownership, as our colleagues here, I think, already have made the imperatives very clear, and reflecting a little bit on the Uganda experience out of these 3 studies we've done. Many times, of course, ownership comes when the successes become hard to maintain and to appropriate to the donors. And so now it becomes kind of transitioning is the word I'm hearing. But I think in our finding, we found 3 main areas where I think ownership might actually play a key role. As the minister said, we really needed to optimize the space for the exercise of sovereign rights and control. And in there, I'm mentioning about 3 areas. That is country policy design, as the minister also said, country implementation arrangements, and of course, accountability for results. He had 4. We looked at 3 which comes across our findings. And in there, of course, accountability for results is important that we all kind of take credit, including country or recipient countries, taking credit for the successes as well as taking the blame for failures. One of the challenges, and I had this example when the minister was speaking, when they talk about putting the countries in the driver's seat. I remember the lessons of driving which I had with my uncle who owned the driving school. And these driving cars, most of you know that the teacher has some controls and the learner has controls. but the process is that the teacher wants, with the time, or the shortest time possible, to hand over all the controls to the learner. But in development, and particularly recent past, you see that the controls are almost maintained for expediency with the teacher, and somehow the student is just watching as the car is moving. So it's not only choosing the direction, but also manipulating the controls. And I think as we move on, it is important to see how we could actually use this example to build development by getting our development partners to allow and to have a specifically defined time to really hand over more and more of these controls around policy design, implementation, but also who accounts or who appropriates the benefits or outcomes that come through. And I think that's where I would think that as we go along, we really need to see how this can be enhanced or put into plans, because I believe the Uganda has generated a lot of news in here, even in the US and back at home. When the going gets tough, it is the government that of Uganda that needs to actually account to its people, but sometimes you find the people they are asking the US government to account, which I think is not probably what would further the whole dynamics of sovereign rights.
Freddie, I want to ask a follow-up because you used that wonderful analogy of the driving school, but to take it to Uganda, can you give us an example of something specific in the whole question of the donor supporting the strengthening of local institutions, where something could be done now that's not been done, or where something was done well over the past couple of years that you've been involved? Something specific. We have a number of people in the room who are actually practitioners who face this kind of choice on a daily basis, and I wondered if you could illustrate it for us in a practical sense.
Thank you. Actually, institutions usually are those, in a car, of course, you'll have a GS steering, but I think when we're talking of governance, it's the institutions that really hold these controls. And somehow, in Africa and Uganda and several of our countries, we've found in these studies that there have been a lot of new institutions, some actually superimposed on existing ones, to try and achieve the objectives that development partners really want to achieve. For example, Global Fund, when it was starting, it started the multi-sectoral approach, and it took the NAC, or National AIDS Councils, as a new institution across all the countries where it was working. The Global Fund also had CCMs, or this is Country Coordinating Mechanism, and local fund agents. These were new institutions that, again, got superimposed on the existing institutions. The US PEPFAR, I think it basically turned the embassies at country level into Ministry of Health, competing ministries. So in a sense, you see all these institutions at country level competing and sometimes generating conflicts which are not really going to help improve ownership. The legitimate institutions, you find they can't really perform their legitimate roles because these roles have either been assigned to new institutions or there is a lot of tension and competition around them. So we see leadership and governance generally being fractured. And that is not good when we're trying to build more ownership or build capacity for ownership.
Thank you. Caesar, in your country, in Zambia, I know one of your concerns has to do with the sharing of financial information about upcoming allocations and disbursements, which is really central to planning. And I wondered if you could tell us about that concern, and in particular in your country where you've seen it work or maybe not work so well, and suggestions for an improvement.
Thanks, Lawrence. I think just in very brief, one of the issues that we have seen from the research that we have done over the past 3 or so years is really about financial information sharing and the lack of transparency under PEPFAR 1. And bearing in mind where I come from in Zambia, the fact that the government basically owns about 80 to 90% of the health infrastructure. It became quite a challenge for the government to plan and to actually understand what the partners were bringing to the table so that they could prioritize their allocations accordingly. So going forward, I think an important thing is really to ensure that there are some instruments, some mechanisms that make sure that information flows readily and is able to help governments and donors mutually plan for health interventions, including HIV interventions.
Our friends from the U.S. government, you've heard from our country researchers. Is there anything that struck a note with you one way or the other, struck a chord? I mean, I think one thing I hear coming out across this is that there was a lot of learning that happened in PEPFAR 1, and I like to think that the work that Nandini led together with her research partners maybe contributed to that process. And so we're at an interesting time where PEPFAR 1 is concluded, we have PEPFAR 2, we have the Global Health Initiative, and so, you know, going forward, how can things be different? And I want to make it as concrete as possible because I think there's a risk with this topic, at least maybe others don't have this problem, but I have the risk that it winds up sounding kind of vague. So I'm interested in, you know, whether you heard things that you think would help you in leading this work forward. And maybe, Janice, maybe again we'll start with you because I think people are especially curious about the Global Health Initiative because it's the big new thing on the horizon.
Thanks. Actually, I wanted to pick up the conversation about swaps and for establishing priorities for getting back to Minister Tedros' it's as a way to align. And I wanted to pick up the experience that I've just come from Nepal, having been there last week. And Nepal is touted as very much far ahead because they do have a swap that includes pooled and non-pooled funders. It's a signed agreement. They actually move through joint assessment reviews. But we had a very interesting talk with all players from government and also with all the donor partners. And it's interesting because I think we talk about these terms, but we don't go down to the next level. And one of the things that came out of Nepal is that what does this mean in a fragile state environment? And I'd like to hear from our colleagues about what are the flexibilities? What's the, I would put it as the tough love that needs to happen in that situation. In Nepal, what they're finding is they've all agreed, and so they've aligned programming. But now they're at the point where the budgets that were put into the swap are not being followed by the Ministry of Health. So we're talking about, well, what is the role of those who are signatories to a swap, whether you're a donor or whether you're government? How do you get with, how can you get to candor and transparency and dialogue and making sure that things are moving as designed? And what happens when it doesn't? So I'd just like to put that out there because I just want to bring this down a little bit to a bit of more of a reality check and hear from some of our other colleagues about some of the thoughts they have about that.
Don, were you wanting to say something?
No, I'll just take this moment to provide a little bit of clarification about the Global Health Initiative because at times there have been bits of confusion, which we want to clear up. First, there was a comment made about Ethiopia being a GHI plus country, which it indeed is, or GHI country. It's not only a GHI country, but a GHI plus country and a beacon of light to many of us. But we did want to make clear that all countries to which the U.S. provides global health assistance are GHI countries. So there was some fanfare last week about the announcement of the plus countries. And then the other point is that there are three primary implementing agencies, although we're really striving for a whole of government approach. But the operations committee for GHI is made up of the CDC director, the USAID director, and the Global AIDS coordinator. And then we have a larger strategic council with representatives from the Department of Defense, Department of Treasury, MCC, and other important players. So just wanted to clear that up going forward.
Thanks very much. Yes, Buck.
I think following up on Bo's points and as you challenged us trying to get a bit more concrete, I referenced partnership frameworks, but countries are now in varying stages of developing partnership framework implementation plans for the second phase of PEPFAR. And in many countries, there is a very high degree of commitment to the kind of transparency that Cesar was talking about in terms of making sure that our host government counterparts are very aware of the plans that are being developed as they're being developed, not after the fact, not being informed, but actually participating in the development of those plans. Don and Janice also mentioned whole of government, and one of the fascinating experiences for me in Kenya, sitting with my Government of Kenya colleagues to develop the partnership framework, was how much they embraced the opportunity to have the whole of their government be part of the conversation, because very often I think ministers of health feel like they're out there on their own trying to do the best for their people without the rest of the government behind them. And when we started the conversation in Kenya, we had 8 line ministries, including foreign affairs, finance, defense, gender, youth, and sports, all at the table, all part of the conversation, all confirming decisions as they were made. And I just had the opportunity to revisit Kenya, feeling very much like an IDP here in the US and sometimes an IDP in Kenya. And I had my colleagues and friends in the Ministry of Health say that having finance at the table during those conversations about the partnership framework was for them inside the government an absolute game changer. And if someone saw the news just last week, after talking about it for years, there actually is now a dedicated line item for procurement of ARVs in the government of Kenya's budget. There's real conversation with Parliament about dedicated funding streams for the HIV response. And I think much of that came about because we were all at the table together on both sides of the table.
It's so interesting that you mentioned having finance involved, and I want to take the opportunity to mention that something that's not really at the core of, well, it is at the core of our agenda today, but it's not represented here at the table, and this is the idea developed by Nancy Birdsall and Aya Magoob at the Center of Cash on Delivery Aid, which is to make contract in advance for agreed upon improvements in a specific indicator, and then make to make progressive payments, make payments for each, what's the word I'm looking for?
Outcome.
No.
Tranches?
No, it's another word. That you pay according to very small improvements. Incremental, yes. Thank you. Incremental payments, and specifically these would be payments based on an individual outcome. And the idea is developed most strongly in education. That is an additional payment, for example, of $200 for each child who completes primary school and takes a test. But we're also beginning to look at this in health, in particular for maternal mortality. And my colleague Mead Over, don't know if Mead is still here, has developing a proposal for incremental payments based on reductions in new cases of HIV/AIDS. And so a number of us in the center think that this kind of approach may be a way to square the circle in terms of country ownership. That is, the support can still be provided, but the donors can get out of the business of specifying how the particular outcomes should be achieved and leave that to the country to decide. So, Buck, when you say important that the finance ministry was at the table, we think that when these payments are pre-contracted, the finance ministry will be at the table because it's going to be interested in those payments, and it'll also then be able to allocate those as it wishes.